If you are worried you have Lyme disease, or just like the outdoors, and want the peace of mind of knowing whether you have Lyme disease or not, there is a new Lyme screening test based on decades of research by Dr. Richard Marconi, a professor at VCU Medical Center. For more information, visit glymedx.com. That's glymedx.com, or email at info@glymedx.com.
Infectious diseases, research, medicine, health. Welcome to Outbreak News Interviews. And now, broadcasting from the Outbreak News Skylar Studios in beautiful West Central Florida, here is your host, microbiologist and editor of OutbreakNewsToday.com, Robert Harriman.
Well, hey everybody, this is Robert, and welcome to Outbreak News Interviews. Now, we've discussed the use and the misuse of antibiotics and the topic of antibiotic stewardship a number of times on this show, and today we're going to look at the use of vancomycin. And joining me to talk about vancomycin is infectious disease physician and returning guest, Stephen LaRosa, MD. Dr. LaRosa, welcome back to the show, sir.
Thank you for having me, Robert.
Okay, well, let's start out with a bit of basics for the audience in case they're not familiar with this antibiotic. Dr. LaRosa, what is vancomycin and what types of bacterial infections is it effective against?
Well, vancomycin is considered a glycopeptide antibiotic, and it inhibits cell wall synthesis predominantly of gram-positive organisms. Gram-positive organisms would include organisms such as Staph aureus, Streptococcus pneumoniae, Strep viridans. So gram-positive agents only. Has no effect against gram-negatives like E. coli or anaerobes such as Bacteroides. So it's often used in pneumonias, skin and soft tissue infections, and in bacteremias, particularly with Staph aureus or in MRSA.
How toxic of an antibiotic is this?
Its main toxicity, people obviously can have allergic reactions, but its main toxicity, which is really concentration dependent, is nephrotoxicity, kidney injury. Mm-hmm. And that tends to go up precipitously once you start getting over 3 and even 4 grams a day of treatment.
Now, I remember many years ago reading that vancomycin was worth more than gold by weight. Now, is vancomycin still that expensive today?
No, it's off patent now, so it's generic, and by antibiotic standards, it's remarkably cheap. You know, when vancomycin was first produced, it wasn't a very pure substance, so there was a lot of toxicity. It was called, it might be of interest to people, it was called Mississippi mud because it was so impure, but that's all been worked out. It's a very pure substance, but it's a generic and it's really inexpensive.
And do we see a lot of resistance to this antibiotic?
So we've encountered resistance with Enterococcus, which can cause urinary tract infections and intra-abdominal infections, so-called VRE, vancomycin-resistant Enterococcus. But VRE tends to be an infection of people who've been in the hospital quite a bit and tends to be more of an indolent process, but we see that. But what we're starting to see, which is more concerning, is a creep in the amount of vancomycin that's needed to kill Staph aureus. And so we've seen Staph aureus with intermediate sensitivities to vancomycin, and there have even been cases, fortunately not that many in the U.S., of vancomycin-resistant Staph aureus. But that's the concern, is that this creep is going to continue and that vancomycin will become superfluous at some point.
Yeah. Now, on your blog, My Thoughts on the Future of Infectious Disease and Medicine, you discuss the use of vancomycin, how to optimize the use, and the dosing of the antibiotic. before we get into that, do you find that this antibiotic is frequently inappropriately used?
I would say it's overused. So, and what I mean by that is that it's used sometimes for people who have gram-positive infections and it's used because of a reported penicillin or beta-lactam allergy. And when you talk to patients, roughly 10% of patients will report that they're allergic to penicillin or cephalosporins. Of those 10%, probably only 10% of those, or 1% of the overall population, is truly allergic. So vancomycin is being used many times because of a reported penicillin allergy that doesn't really exist. And why that's concerning is we know that for gram-positive infections where the organism is sensitive to beta-lactams, the outcome is much better if you use a beta-lactam drug like penicillins or cephalosporins rather than vancomycin. So you're, in effect, often using a drug in vancomycin that is inferior when you don't need to or when you shouldn't.
And the inappropriate use is another downside to that, the possibility of increased resistance?
Yeah, I mean, you're just exposing the population as a whole, and so you're giving selection pressure to organisms to become vancomycin resistant, and we'll get into the dosing, how that does it as well. But you're giving people vanco. The other thing is there are ways to check patients to see if they're truly colonized in either their airways or their axilla or perineum, to see if they're carriers or colonized with MRSA. And if they're not, there's good data that you don't need to give people empiric treatment with vancomycin. So the other big issue is you're giving vancomycin to people who aren't colonized with the organism that you're really worried about, which is MRSA.
Mm-hmm. Now, going back to your blog post, I was going to ask you, so how do you, as an infectious disease physician, evaluate the need for using vancomycin?
Right. So some of this is detective work. So it's true in infectious disease that what has happened before tends to happen again. So you need to have a history of the patient's previous infections. Fortunately, in this day and age, more and more facilities have an electronic medical record that is readily accessible, and you can go back, and there's a couple things I look for. One is I look in the medical record for evidence of past infections with methicillin-resistant Staph aureus, with MRSA. The other thing is more and more facilities are checking people for colonization. So I look and see what the patient's past history has been, and that is very useful. The other thing is when someone comes in is to sample their nares and their perineum for Staph MRSA colonization. In pneumonia, I check their nares in their throat, and if those are negative, that's a pretty good marker that their infection, be it a pneumonia or their skin or soft tissue infection, is not likely to be MRSA. And in that case, you don't need vancomycin.
Now, can you explain what a loading dose of vancomycin is and why that's important?
Right. So vancomycin, like all antibiotics, has a half-life, and it takes 5 half-lives to achieve steady state. And if you dose vancomycin kind of the traditional way, which is 15 milligrams per kilogram every 12 hours, we know that it takes about 2 to 3 days in that setting to achieve a steady state concentration, which in somebody who's bacteremic or severely ill is excessively long and may lead to a poor outcome. So what has been found is that if you give an upfront loading dose, and probably the optimal loading dose is 25 milligrams per kilogram with a cap of about 3 grams total on that you can significantly shorten the amount of time it gets to get up to therapeutic concentration. So my practice is to load everyone, irrespective of their baseline renal function, with 25 milligrams per kilogram up to 3 grams, to assure that I'm getting them up to a therapeutic level quickly, which is critical in critically ill patients.
Of course, and if you don't do that, it just extends the amount of time to get that blood level to be effective.
Yeah, so vancomycin is an interesting drug. It's not only getting up to a therapeutic level, but it's time that you're exposing the bacteria to that level. So it's both concentration and time dependent. So it is critical that you're giving the organisms the appropriate exposure. So that pharmacokinetic term is the AUC, which seems to be critical.
Now, in your blog post, you go into some very deep detail concerning dosing. And I was hoping that you could maybe give us a nice, simple Reader's Digest version for the audience.
Right. So all too often, as I mentioned, there is a dose of vancomycin that's written for 1 gram every 12 hours, and vanco it's actually quite a difficult drug to dose to do it right, because as I said, it's both the time that you're achieving having a concentration and the level, the AUC. So it's very important that you try to get it at this pharmacokinetic target of what's called the AUC to MIC ratio. And the magic number for efficacy, both from animal studies and human studies, is an AUC to MIC ratio of 400. Now, if you read guidelines, they won't talk a whole lot about this. They talk about measuring trough levels, so a level of vancomycin given before a dose, and they use that as a surrogate marker. But it really isn't a surrogate marker. It really isn't a very good surrogate marker for what you're trying to achieve. So without getting too complicated, what you want to make sure what you're doing during vancomycin, which is commonly given Q12 hours, is to get 2 levels of the drug within a dosing interval. So if you're giving it every 12 hours, typically what I'll do is give it an hour after a dose, that's the peak, and give it a half hour before then the following dose, which is the trough. And with 2 levels, there are a variety of programs that are available, and for the listeners, there are calculators available. In fact, I have a calculator on my iPhone called Vancomycin Calculator, where I can plug those 2 levels in to the calculator, and it will tell me if I'm achieving, based on population pharmacokinetics, if I'm achieving an AUC to MIC ratio greater than 400 with that particular dose, or whether I need to change the total dose or the frequency.
Oh, pretty cool.
There are also some other equations that you can use, but the long and short of it is the vancomycin trough, which people have been focusing on, is really not indicative of or doesn't correlate with efficacy.
Now, as an infectious disease physician, is the use of antibiograms important to you as far as deciding to use vancomycin at all?
Absolutely. So all too often labs will, when they give an antibiogram for an organism, they'll report resistant R, intermediate I, and sensitive S, and people focus on that. But what matters is the actual MIC number, and this is true of vancomycin. So there are infections with vancomycin with an MIC of 2, which is considered sensitive. So it tells the clinician, yeah, vancomycin is a reasonable choice. But unfortunately, if somebody has renal function that's fairly normal, the amount of vancomycin that you have to give to achieve an AUC to MIC ratio more than 400 sometimes is in the order of 5, 6, 8 grams a day, which is really prohibitive in terms of the incidence of nephrotoxicity. So And there's also good data when vancomycin MIC is 2 that the outcome is worse when you give vancomycin. So when I look at an MRSA infection, I pay close attention to the vancomycin MIC, and if it's 2, even though it says it's sensitive, I choose an alternative agent.
Okay. Dr. LaRosa, any final thoughts on the use of vancomycin?
Well, I think vancomycin still, there are people who said vancomycin's passé, it doesn't have a role. I think vancomycin's useful. I think the key takeaways are, do you really need it? Does the patient have a history or something that makes you suspect they have MRSA? If so, then it's a good choice. Don't give it for sensitive Staph aureus infections if there is not a strong history of a beta-lactam allergy. And then when you do use it, try to dose it correctly, give a loading dose, and then get a peak and trough level and use one of the programs available to make sure that you're achieving the appropriate target, which is an AUC to MIC ratio of 400.
Okay, very interesting. I want to thank you, Dr. Stephen LaRosa, for your time and expertise on this topic.
Thank you very much for your time.
You bet.